All right, welcome back. Hope everybody took advantage of their break and are ready for what may be a little more controversial second half, which is our talk about management of solid organ injury and then management of pancreatic trauma. And then we'll close with what do we do about DVT care? So I think these will be a little bit more controversial topics, and no better person to lead us off but Dave Mooney. Dave is the director of the trauma program at Boston Children's, the founding president of the Pediatric Trauma Society. And many of you in the U.S. who have a trauma program have probably seen David as you're doing your site review. So with that, I'll welcome David to the session to talk about solid organ management.
Thank you, Rich, and thank you guys for having me speak. I'm going to be speaking with David Notrika from Phoenix. And actually, David, I think your slides would go better in front of mine.
Yeah, we probably should have communicated that to Rich. Yeah, David and I had spoken, and I was going to start, and if that's okay with you guys.
Wonderful. I'll let you. So I didn't do your introduction now, so you're throwing me off. So Dave Notrika is the director of trauma from Phoenix Children, started that trauma program and has kept it viable, and we already heard about one of his big contributions to the literature about trauma centers having an impact on care. And I'm sure as he talks, we'll hear about some of the work he's done with the Atomic Group, their research collaborative on solid organ injury. So, David, I'll let you take it away.
All right. Well, thank you very much. I am going to do my best to share my presentation and make it full screen. So, well, first of all, I'd like to thank Todd and Rich and the rest of the Childress Institute and Cincinnati Children's for the invitation. I'd like to thank Dave Mooney for collaborating with me. It's so much easier when if you're doing a talk with someone, if you actually have a chance to spend some time with him. And Dave and I actually got to talk about this so that we have a cohesive message, or what we think is cohesive. Our first case, this is interactive, so we're going to present an 8-year-old male who was riding his bicycle when a car struck him. He had no helmet. He had a loss of consciousness for 2 to 3 minutes. He was combative. His heart rate was 127 and blood pressure 141 over 77, respiratory rate of 22 and SATs of 99%. His shock index, if you believe in that, was 0.9. He had, and some of us are starting to, he had some facial abrasions, right wrist deformity, and a negative FAST exam. Head CT was negative. 6 hours post-injury, the patient complained of abdominal pain and went back to CT scan for a CT of the abdomen and pelvis with IV contrast. And this is what we found. So anybody want to chime in a little bit on this? I know Fenton, if he's still on, is a big fan of FAST exams.
So you have the radiology arrows, I see. So that's helpful.
Yeah, well, that's in case I forgot what I was looking at. So what we see here is we do see a splenic injury, and we see some blood in the pelvis here, and different view of that to give you a little bit more perspective on the injury. And so we got a grade 4 injury. We got 40% devascularization, a large hemoperitoneum, an initial hemoglobin of 13. He's 4 hours post-injury, and his heart rate's 88, and his blood pressure is 140 over 77. And so I'd love to ask the audience, what do you do at this point? Are you going to explore and do a laparotomy for this grade 4 injury and take the spleen out? Are you going to explore and do a splenorrhaphy? Are you going to do an angioembolization? Are you going to admit to the ICU and observe? Or are you going to admit to the floor and observe? I'll go back to the...
Let's invite the audience. We're going to do it a little archaic here. Type your answers in the chat. It looks like, David, everyone is saying go D to the PICU.
Then maybe I'm preaching to the choir. So
talk's over. No.
So we'll admit that patient to the ICU. When you look at evidence for whether or not patients need the ICU or the floor, there's actually good evidence to suggest patients who are never unstable and without signs of recent bleeding or ongoing bleeding, that they're candidates for non-ICU monitoring. This patient has a large hemoperitoneum, suggests that the patient did have recent bleeding, and that patient needs to go to the PICU. So that is the correct decision. A little bit about the atomic guideline. We developed this starting in 2010 with the Arizona, Texas, Oklahoma, Memphis, Arkansas consortium. It was a lot of work. This is version 11. We got to version 10, I think, before we ever really started using it on people. So what it says is that patients who are unstable or who were unstable or who bled recently get managed one way, and those that have never bled get managed in a very different way. And this is not rocket science, but the APSA guidelines really said that it was grade of injury that determined care, and there's going to be a lot of overlap between grade of injury and recent bleeding. But the real determinant is really going to be whether or not they bled recently, not whether or not they have a high-grade injury, because there's some high-grade injuries where there's no blood anywhere other than the organ itself. We call these lacerations, but actually, in truth, some of them are probably just bad bruises inside the organ. So that's the atomic guideline. So what are the chances of non-operative management failure for this patient? Is there a way to actually look to see what people are typing? We'll have Todd relay that to us.
That's what I'm doing now. Yeah, leave that up there for a second so people can start. Looks like we're getting all sorts of answers here. C, D, B.
What's the panel think?
So let's let John speak first.
I'd put it at 5%, maybe even less.
Okay.
I mean, yeah, I would agree with that.
Yeah, I think we all on this panel would agree with around that 5%
failure rate. So, the risks of failure of non-operative management overall, they're not very many, and 5% has been reported. If you look at the home study, which really looked at, and there are a lot of, I think Dave Moody is on that study. It's in spleen, you're really looking at about a 4% failure rate, and so that's definitely in the ballpark. Livers fail a little bit less. If you look at mechanism, patients who fall are less likely to be injured, but those that have injuries like this patient, motor vehicle collision, they have an average risk of failure. But the things that are predictive, higher grade injuries, grade 4 has a 5 times greater chance of failure, and a grade 5 has a 58 times greater risk of failing. ISS certainly increases your risk, as is a low Glasgow Coma scale and multiple injuries. The things that are not particularly predictive of failure are low-grade injuries. So a grade 3 injury, believe it or not, is not that much more likely. It's not statistically more likely to have failed than grade 1. Age doesn't seem to matter, and gender does not seem to predict. But hypotension at admission, transfusion, hepatic artery embolization for liver injuries, peritonitis is the first exam. Low initial hemoglobins, what this patient doesn't have. His hemoglobin was 13. Large hemoperitoneums are predictive, and then hypotension without preoperative transfusion also predicts failure. And so, we think that this kid's probably higher than the 4%, probably in the 5% range. Does the time course matter? So, you have to ask yourself, if this patient who's now survived the first portion after his injury, is he going to fail? And in adults, adult patients fail kind of linearly. So if you look at this study from Heitzman et al., you've got about a quarter of the people who failing in the first 12 hours. Surprisingly, 12 to 24 hours, you still have another 20% of patients failing, and you have patients failing at 24 to 48 hours. And it's quite remarkable that it's not very front loaded. Kids are very different, and so the study from Holmes et al. Basically shows that kids fail early. The median time to failure for kids, I'm sorry, there's a helicopter, it's about 3 hours. So, yeah, it's not for me. I'm good. The median time to failure is about 3 hours, and about 40% have failed by 2 hours, 60% by 4 hours. And once you get to 12 hours, 75% of those who are going to fail have already failed, but which I think is a little bit reassuring. It's important to know that where the patient is taken care of does matter. So there's several studies that find outcomes for adult trauma centers are the same as pediatric trauma centers. There's a study called Teen Trauma Without the Drama, which showed that in Ohio that the results were similar, but the results that they looked at were length of stay, ICU, and survival, and they didn't really look at non-operative management as an outcome. I think that's a bit of a drawback for those of us who are pediatric trauma specialists, that we think that non-operative management is an important outcome. The Pennsylvania Trauma Systems database looked at these teenage kids, did multivariate regression, and found that pediatric trauma centers have less frequent emergent laparotomies for all patients with an odds ratio of 0.65. So certainly a significant number of less emergent laparotomies. If you go back to the Densmore article, which is now about 9 years old, it looked at 27 states, 80,000 patients with spleen injury. Your odds of splenectomy really varied by where you were taken care of and who you were taken care of by. So if you were at a non-trauma center, you were twice as likely to have a splenectomy. If you were at a general hospital versus a children's hospital, it's about 2.8. But you really see a difference in general surgeons versus pediatric surgeons. So a general surgeon would be four times as likely to do a splenectomy than a pediatric surgeon. And if you were an adult center versus a pediatric trauma center, you basically saw a six-fold risk of having your spleen taken out. Nice study in JAMA by Bowman. It's hard to ignore this study. This looked at 2,800 patients. They adjusted for patient characteristics, injury severity, and hospital characteristics. So it's not just all takers. This is a very well done risk-adjusted study, and it found that the risk of splenectomy was 5 times higher at adult versus children's hospitals.
So I'm just looking at the opposite of that. So if the adults are more quick to take out the spleen, do the pediatric surgeons transfuse more? What would the adult arguments say to us that why are we taking too few out?
Well, it's interesting. So one of the things, and this was not in the Holmes paper, but if you start looking at the literature on failure, a lot of the kids that fail were never transfused, and so it's not, you have a patient who comes in and they are pale and they have signs of shock, and some of those are going to the operating room without ever getting a trial of transfusion, and so I think that may be a significant factor. I think that if I were to try and manage adult patients with injuries that look like my pediatric injuries look, I think that I'd have a lot of adult patients who failed, and I would get very scared, and I wouldn't be able to do what I do with kids.
Interesting. Yeah.
What, David? While we're taking this stop there, what do you think about the argument that, well, if you don't have a pediatric ICU and you don't have pediatric intensivists and you're not a ped center used to dealing with these kids, that maybe it is safer to have a lower threshold for removing the spleen earlier?
It's interesting because once we start to get more data about when kids fail, and we start to understand that, because a lot of these centers that are not that don't have a pediatric trauma center within a reasonable distance that they can transfer to a pediatric ICU, the patients are also taking longer to get to that center. And so some of those patients who are stable have already gotten past that highest risk window. And so, you're 12, you're 4 hours out, your patient's stable. You have a slight chance that they're going to fail in the next 12 hours, but really the curve starts going way down. And so I don't know that you can justify operating on a patient who has stabilized simply because you don't have a pediatric intensive care unit.
Great.
Dave, Dr. Mooney, you want to jump in on that?
Oh, yeah, sure. So, well, it's interesting, the slide that you're showing. compares adult trauma centers to pediatric trauma centers, and certainly for most kids over the age of, say, 8 to 12, you can start to quibble about the two centers, but any adult trauma center ought to be able to manage non-operative splenic injuries the same way that they do for young adults. And I think, as David had mentioned, the risk stratification in these studies is key. You stratify out the gender, mechanism, and grade of injury. You still see a differential between the centers. It's probably related to the training of the person standing at the bedside and their mindset, not so much the patient.
And I think that's our responsibility as well. I mean, if I have general surgery residents rotating through from 4 surgery programs, just like a lot of other children's hospitals do, and and they're spending time with me, and I have to teach them enough about pediatric trauma that they can actually do a good job of managing these kids if they're in a situation or a setting where that's part of their responsibility. So I think, again, this comes to education. We need to make sure that we show them that an injury like this actually can be managed non-operatively very successfully. So that's on us again. So I think this has been up here long enough. Basically, spleen surgery was performed more frequently at adult trauma centers, 7.7% versus 4.9%. And, looking at the co-founders that we talked about, they're just more likely to operate. And, there's no practice variation that you see between adult trauma centers and pediatric trauma centers regarding kidney and liver. You're still seeing this difference in spleen injury, and I think that's probably where we need to focus our education on. So, why do children fail? Shock, peritonitis, continued bleeding, intestinal injury, pancreatic injury, diaphragm injury, and so it amazes me that it's not all that the spleen keeps bleeding. When you look at that failure rate, a lot of it's for reasons other than the straightforward continue to bleed. This was a patient that was a young abused child, and we managed him non-operatively. And we were very surprised that he failed non-operative management because he basically developed a compartment syndrome. And I've cut off some of the chest, but basically he didn't have much lung volume there. He basically had bad peritonitis, and so he wasn't a great candidate to continue managing non-operatively. And when we did operate on him, he's not bleeding, but he's got a crack in his liver that basically has bile draining right out of it. And so sometimes in younger kids, they're going to fail for reasons that you may not predict. And when I say he had intra-abdominal compartment syndrome, I mean his intra-abdominal pressures, he was difficult to ventilate and his urine output was down. And we left him with an open abdomen. Afterwards, we did a hepatography with omentum, and which was good for him, but the main thing he needed was his abdomen opened. So a lot of kids are going to fail for peritonitis, and those with intestinal injuries are going to need surgery. Initially there was a lot of concern that we should be operating on these patients because with solid organ injuries because we'd missed an intestinal injury. And then Bob Letton and the APSA group, I think Dave was chair of the trauma committee when that happened, did a multi-center study and basically showed that there's really no need for urgent exploration if the diagnosis is in question. So the patient's time to surgery didn't correspond with complication rate or death, and these delays, which were 24 hours and 48 hours in a lot of cases, did not portend a bad outcome in these patients. So appropriate observation, serial examination is certainly reasonable. So when it comes to continued bleeding, splenic blush is an area of controversy. In the adult trauma centers, it's very common if you have an angio, if you have a contrast extravasation, that you immediately embolize that. But in children, routine splenic artery embolization doesn't actually improve salvage. But there's a nice study showed that as an alternative to splenectomy, it certainly may have some benefits. And so those are patients who are failing because they are continuing to bleed basically dropping a coil into a bleeding splenic vessel may prevent you from having to take the spleen out.
When would you embolize someone then?
So it's interesting because we embolize very, very few patients. We actually have a huge interventional radiology department. They would love to embolize these patients for us. They're very collaborative. At the end of the day, the very rare patient who continues to bleed, despite time. And time, I think, is the most important. Those are the patients that are candidates for angioembolization. It is not based on the appearance of the CT scan. It's based on continuing physical exam evidence or laboratory evidence that they are having ongoing bleeding despite time.
Sorry, I don't want to beat this, but so you got the patient, they failed, they're bleeding, you've transfused them, you're ready to go to the OR. Can you stop in the angio suite? I mean, I think that's what you're alluding to. I know the numbers are so low, but would you do that?
I would, and I keep in mind, that also corresponds to the fact that our angio folks who are very responsive, they still need an hour to get there, and so that's those are the patients that are perfect. The picture that you see in the study is an image that I never should have obtained. This was before we had trauma centers, and my patient came in and needed an operation. She was in a bad motor vehicle collision and had a lap belt injury, and couldn't move her lower legs and was pale as a ghost. And it wasn't a trauma center. We were a hospital within a hospital at the time, and there wasn't an OR ready. And so I took him to CT because I needed something to do between the time that I left the trauma bay and the time I got an operator. And so that white stuff that you see in the left upper quadrant is all extravasated contrast. And when we did operate on the patient, I didn't have to do a splenectomy because it had already been done. And all I had to do was find the splenic artery and vein and ligate them and take out the pancreas and the distal pancreas with it, because they were literally floating free in the abdomen. So I'm not saying that there is never a patient who needs a splenectomy. This patient needed that. But it's not going to be that many.
So, David, I had one more question on that. Not to kind of, I know it's a topic that comes up both with adult surgeons and some with pediatric surgeons, which is, I think our protocol might be a little different, and maybe there's something to learn here. But I think I would say we would probably go to the OR if you had a blush. I mean, if you had a blush on that initial CT, and then you're failing non-operative management, meaning you're continuing to have transfuse, you're continuing to have shock. Those are the kids that we would go to IR. The kid that did not have a blush, I'm not sure our practice has been, go to IR first. If they failed and they didn't have a blush, we've generally gone to the OR. It's rare, as everybody. I mean, our splenectomy rate, like what's published, is in the 1-2% rate, but so is our intervention rate. So I don't know. I'll ask John here as well, kind of what you would do.
Yeah, I think contrast blush is a little bit misleading. I think if all of our patients crashed their car into the CT scanner, we'd have 100% incidence of blush on the CT, because there's a time factor that's there. So patients that may come from an outside hospital that have had a scan sort of very soon afterwards may have a blush then, but as David's already said, time is in some ways on your side to tell you what that means. So I think probably the hemodynamic side of that, particularly as you talk about embolization, you have to sort of factor that in about what you anticipate finding with either a trip to the IR suite or to the operating room.
I think one of the other things, and we altered the atomic algorithm, the one that before publishing in Journal of Trauma, we altered it about a year prior to publishing it. And patients who have a second episode of hypotension or blood pressure less than 50 after they've received blood, really cannot be managed in an algorithm sort of way. So at that point, if you have a second episode of hypotension, because hypotension in kids is ominous, it's uncommon, an algorithm is not going to tell you how to manage that patient. And by that, I'm not saying that you failed, but I'm saying that you can't continue business as usual. You need to consider operating, consider angioembolization, and if you're going to manage that patient with a second episode of hypotension non-operatively, you need to have pediatric surgeons and an OR immediately available. That is not a good candidate to simply keep at a community hospital. So going back to your first question, yeah, there are patients who need their spleen out.
So, David, if I could just chime in for a moment. Now that the fire alarm has stopped at my place, we just looked at our last 600 and change kids with spleen injuries, and we did one splenectomy, didn't do any splenorrhaphies, and did 11 embolizations. And those were kids. A couple went right from the ER, a couple went sort of later. But it's we have very aggressive, like David, we have very aggressive IR people. It's usually fine, but sometimes it's kind of frightening. And the child's actively bleeding, and they're sitting there in IR, while they're getting access and prepping and draping and doing things in a little bit different time frame than we like to do things. It's worked out okay, but again, it's not for the timid. And you've got to have surgeons willing to stand there, while everyone's getting ready, just in case things go poorly. But I would definitely not do that in a non sort of high-end PD center. Just because the difference with a pediatric IR versus adult IR is meaningful enough that a lot of adult guys are very gun shy about doing it in a kid.
Yeah, thanks, Dave. I agree with you completely. I can't tell you what to do with that patient in that situation. Once you've had a second episode of hypotension, it really depends on where you're located. Sorry, I'm kind of going over, so I'm going to try and wrap up quickly. But basically, delayed splenic bleeding is a big concern, but there actually have only been about 14 patients reported in the pediatric literature of delayed splenic bleeding. It was nicely reviewed by Davies, and basically 7 of those 14 were not delayed splenic bleeds, but were actually delayed presentations. The mean time to delayed splenic bleeding was 10 days, which means that in order to get 50% of these delayed splenic bleeds to happen in the hospital, you're going to have to change your length of stay to 10 days. That's going to be problematic. The incidence of delayed splenic bleeding, Davies reported as 1 in 300. I will tell you that I think that when we come out with our data next year from the multi-center atomic study, that you're going to find that the incidence of delayed splenic bleeding is far less than 1 in 300. And so we'll be publishing on close to 1,000 patients with blunt liver or spleen injury. At least half of those will be spleen only, and I think you'll see the incidence is much lower. Should we re-image? Well, you have to think about what you're looking for. Are you looking for a splenic cyst, a pseudoaneurysm, continued bleeding, or signs of healing? If you look at for pseudoaneurysm, what you'll see is that of patients that were observed, most of them resolved without intervention. The one that did not actually had a splenorrhaphy. And to me, a lot of times, I'm not knocking splenorrhaphy, but I will tell you that if you can manage it with a splenorrhaphy, there may have been another way to manage it, potentially. So probably not a good reason to reimage just to look for a pseudoaneurysm. When we say why do kids fail, written protocols, better adherence to sound clinical judgment would reduce the incidence of failure of non-operative management. And I think that just having a protocol itself will go a long way to improving your non-operative management. All right, thanks.
Wait a second, that's it? I got so many questions for you. Wait a second.
Well,
I know you only have like 10 minutes.
And I are supposed to be splitting the time,
oh,
although
okay. All right, fine.
Go ahead, Jude.
Oh, can you stop sharing your slides? They asked me to ask you.
You don't like my dog?
I love your dog. Actually, keep it up. Let's tell them they can go jump in a lake. All right.
Talk over them.
Does he have a
So that's the dog?
We thought that was a self-portrait. Hey, we have a question.
There's a reason that owners look like their dogs.
First of all, I loved that talk. I'm definitely going to be inviting you to come talk to our group. I want to compliment you, first of all, on the atomic study that you're doing. I think if other people could repeat what you're doing in all the other specialties, we would learn a lot more about how we should be managing children. I have a question for you about how did...
Is there going to be a disclaimer on that, Todd?
What's the disclaimer?
That you're part of the study.
Yeah, right.
Thank you.
No, but it's fantastic. There was questions from the audience. There was a lot of talking in class, which we love during your lecture. People asking questions. What is your criteria? Is it 2 units of blood? Is it 3 units of blood? What is a unit of blood? When do you go?
So we actually found reasonable evidence to suggest that 40 per kilo of all blood products indicates that the patient has had an adequate attempt at non-operative management and is likely to fail or to die. And so in the algorithm, we basically say once you get 40 mils per kilo that you failed the algorithm. It doesn't mean that you failed non-operative management, but again, it means that you cannot be guided by a guideline. You have to individualize it based on what you have available and when you got to that. The Journal of Trauma gave us a lot of grief about not saying that you just need to operate on them. But when you have a guideline, you don't know if they're getting there at 2 hours, 4 hours, or day 4. And so somebody who gets to 40 mils per kilo on post-injury day 4 may not really fail non-operative management. And so that's the kicker. And so that's basically you fail the algorithm at 40 mils per kilo or 4 units.
Factor 7 or TX, is it TXA? Do you use that or no?
So TXA is part of our massive transfusion protocol. We activate our massive transfusion protocol for trauma very, very rarely. And so I could gather 10 years worth of data and I couldn't answer your question.
Okay. So in a patient that we talked about that's gotten 40 per kilo, you're thinking about going to the OR. We were talking in our group, may we send, okay, we're going to the OR, but first let's give TXA, let's give factor 7, let's go to IR, let's do those things that haven't been proven, but may prevent it, may keep the spleen. I just don't know where that lies.
As long as you have a massive transfusion protocol, you're going to be in better shape than a center that doesn't.
Okay.
David, do you want to comment on that?
Well, I think it's the idea that if you've thought, like most things, if you've thought about it in advance, worked out a process for something to happen, at that moment when you're, frenzied a little bit internally because you've actually got a really bad trauma patient, it works a lot better if it's laid out when there are reasoned binds in a calm environment. And massive transfusion protocol, definitely. Embolization for us, it keeps us out of the OR for the kids' spleens. We're a little bit different because by the time you slug it out in traffic to get to our hospital coming through Boston, you've had a test of time and your spleen will be fine. But it saved us a few kids. They're really sick if you embolize them. And we've had kids act very ill post-embolization to a point of sort of standing at the bedside wondering whether I needed to do a lap for a peritonitis.
Yeah.
Great. Why don't we go ahead and let Dave do your talk. I have plenty of questions still, but we'll get both talks done and then we can have a bigger discussion.
Mature, is the screen sharing working okay?
Looks great.
Yep.
Okay. Actually, I counted on David going over a little bit because he sent me the slides first, and he had great slides. So I thought I'd be the counterweight with really boring slides and be a lot shorter. And you don't want to see a picture of my dog. So what I want to talk about is liver injuries, and really liver injuries in the sense of, starting off with a question. So just to the crowd, and you can throw it out there on the chat. So what method of diagnosis do you think has the highest sensitivity and specificity? And I initially said best way to diagnose, but you're trying to identify a blunt liver injury. Is it physical exam? Is it lab tests, fast exam, or a CT scan? And we'll talk about that as the talk goes on. What I want to do is walk down. Oh, please.
Everybody has said D or 4.
Yeah, a bunch of cheaters. Okay, fine. So let's talk about a case. So a 6-year-old boy, rear seat passenger, head on MVC, of course. So the father's driving because mom would probably have him better restrained. Lap belt only, alert and oriented to the scene and coming in to you fresh. Pre-hospital, his airway was fine. They put some oxygen on him because they need to do that and immobilize the spine. Started, we were proud of them, a couple large bore IVs, a little bit tachycardic, pressure's okay, a little soft, breathing a little bit fast, statting okay. So, some signs of issue, but nothing dreadful. Physical exam, alert and oriented, complaining about belly and back pain, no peritoneal signs, tender belly, a little bit tender in the mid-spine, but no paraspinous hematoma, no palpable step-off, and he's moving all 4 extremities, which is really nice to see. especially moving his legs. And here's a picture with a nice, kind of a little bit high for a seatbelt stripe, oftentimes a little bit lower, but this nice stripe right across his mid-abdomen where he was sort of flexed in half from the belt from the crash. And just looking at physical exam, so, and this is some data that I've got, I think, 3 or 4 tables like this that were really Rich Falcone's work, or work that was directed by Rich through East, looking at how can we best diagnose intra-abdominal injury in a child. And the East group walked through the literature and looked at different things, like, for example, physical exam. And one of the things that's fascinating, when you look at some of these different numbers, like sensitivity, specificity here, like 73 and 98, or 94 and 31, for, some studies they have a lot of patients in it, especially a home study from 2002. It's very variable between different studies on how good is physical exam at diagnosing an abdominal injury. And it leaves me with thinking, well, it's pretty good, but it's not perfect. And you can't clearly rule out an intra-abdominal injury by physical exam, and you can't clearly rule it in either. It just can either heighten or lessen your suspicion. Then looking at labs, so the next thing, which would have been B if anyone had fallen for that. How about getting labs to look for liver injury? Well, we've actually backed off the labs in our place to just getting a hematocrit, and we're really interested in seeing if that hematocrit is less than 30, because that seems to be sort of a marker for a sick child or not, or a meaningfully injured child or not. But we kind of hope we'd be able to tell that by some other means. We get a blood, UA looking for blood, because I'm concerned if they have a kidney injury or an accompanying liver spleen injury. We draw a chemistry tube, but we don't send it. We don't get electrolytes or coags or things for our standard patients. And we actually found our most expensive blood test was a blood bank, the type-in screen. In our institution, they tell us the cost of that test is $440. Which is probably proprietary information. And I am in Boston, so it's probably $40 other places. But this alone in cost saves our hospital about $250,000 a year, just backing off the labs, and with no adverse outcomes. We've looked at this over a 2-year period, and we haven't had any missed injuries based on not getting labs, all these luxurious trauma labs. Well, what about trauma labs for liver injury? So here's, again, a range of studies, some of them pretty sizable. This Holmes data, again. This is a study from our place, Andy Caparo and I, from 2006, which is scary. It's almost 10 years ago. And you look different levels of ALT, AST, 40s, over 100, 30 and 40, and different sensitivities and specificities. And again, they're fine, but they're not perfect. I mean, we went all the way down to an ALT of 30 and an AST of 40. Went way low to try and pick up our sensitivity, and still miss some kids, even going that low in our lab line. And again, different people draw different lines for what's meaningful for the ALT and AST, but we actually found them to be just not that helpful for us. And fast exam. I love fast exam. It can be very handy. Unfortunately, looking at fast exam and trying to determine if a child's got an intra-abdominal injury using a fast exam. Again, a range of studies, lots of patients. And some of them are pretty good, and some of them are not quite as good. And it's the going rate is the statement is that about 30% of intra-abdominal injuries in kids are missed on fast exam. And it may be partly related to sort of, as John said before, if you check the blush at the scene, that maybe a lot of kids will have a blush and then it'll stop on its own. Well, it could be if you check a fast hours later, they will have time to accumulate fluid in their belly. Well, if you check it pretty quick, maybe they just didn't have time to collect some fluid. Plus, it's really hard to see the organs with ultrasound. And we used to get follow-up ultrasounds on all solid organ injury kids, a liver or spleen, but we found it really wasn't very helpful. And we knew they were still injured, but we just couldn't see it on the ultrasound. So CT is the gold standard. Everyone got it right. Pat yourself in the back. The only issue with CT scan is about 5% of the time, the scan shows you a result that changes your management or indicates an intervention. And that's to do that CT, you're getting about 6 to 10 millisieverts of radiation, and though that's steadily going downward, which is great. At that dosage, at 6 to 10, it's around 1 in 1,100 risk, sort of across all of children, of a later death from cancer. And that we can go back and forth about that number, and people do. But this is a study from the New England Journal of Medicine that was published in 2008. And this is a abdominal CT scan with a fairly standard dose. Pick a 5-year-old. Here's a 5-year-old, and this black square up here is the total risk of death from cancer. And it's the estimated lifetime attributable death risk of death from cancer. And that's 0.09%, which is where that 1 in 1,100 comes from, because that's what that number would be. And this is, again, the total risk per that study in the New England Journal. And they tend to be not the biggest slouches in the world for research. Doses are declining, but one thing that's very concerning for us, this is actually 157 or so, I guess probably 161 would be the right number, who came into our hospital after having an abdominal CT scan for trauma in other hospitals. And this 1.0 is the dose that the American College of Radiology says they should have received. And half of the patients got more. This is really tedious calculating on these radiation doses, but more than half of patients got more radiation than they should have received for the performance of their CT scan. Some of them fairly frightening, the amount of radiation that they got. And so we got our CAT scan, and here's the child's CT scan. Here's the spleen with quite a bit of blood around it, the stomach with some fluid and an NG tube in it. Here's just looks like a Pacific Island chain with pieces of liver. This is probably some extravasation, and also probably some extravasation, and just blood and mushed up liver all around through the middle of the gland. Can't really see the cava the best, but there was no big injury to the cava that we could tell. And one thing just to mention and I'll carry on about it a little bit later, is a contrast-enhanced ultrasound. Here's a picture of a spleen with an ultrasound of the spleen where you can maybe sense there's something there. But here's one with after we gave this stuff called contrast-enhanced ultrasound contrast, which is the little perfluorocarbon bubbles stuck to albumin molecules. And you can see the area of the spleen that's just not being perfused while the rest of it's pretty good. And it's really easy to see the injuries with the contrast. So our child got admitted up to the unit. We were pretty concerned about him. And the question was, at first was if he was even going to make it to the unit, or if he should just go to the OR. And we talked about that. And I was wondering what anybody on the panel, anyone would take him maybe to the operating room, or?
No, I wouldn't. I don't think so. I think going back to Dave's talk about the atomic work, I think you go by hemodynamic stability a lot more than you do on that imaging.
Yeah, I think if he's hemodynamically stable, you would give him a shot at non-operative management.
Well, I remember David Richardson from Kentucky's quote that more patients have been harmed by heroic surgeons operating on their liver injury than by the initial liver injury. That it's going this kid's belly. To me, I'm not exactly sure what I would do. Probably put every pack I could find in the hospital up in that area. But I suspect it could be, especially with a proximity to the vein, get very difficult very quickly. So we put him up in the unit. He got an ileus, got some fevers, and transient increase in his bilirubin. He dropped down to about 17, but then his hematocrit eventually rose. We tend to not transfuse until like 15 to 16-ish, because a lot of kids will dip to 3 to 5 days out and come back up. Got the expected right pleural effusion, because many of these solid organ injury kids get an accompanying sympathetic effusion, and didn't require any intervention. We thought we might have to do something about those little 2 bright spots in his liver and embolize them, but he did not require it. And we normally do grade plus 2 weeks, but I gave him a couple extra weeks because he scared me a lot. And but he eventually returned to normal activity. So talking about complications, this child was able to avoid a recurrent bleeding for liver injuries is actually very unusual. And it's unusual for a child who makes it out of the hospital with their liver injury managed non-operatively to come back for bleeding. Hemophilia is where the ducts in the blood vessels get mixed up as a healing. You get some blood in your bile. I've actually never seen that. I've heard about it, and I'm interested to see if anyone else has ever seen it. They read about it. Fevers are very common. Our patient had just a large volume of damaged liver tissue intact, which is very inflammatory, and they get a really big inflammatory response to that and remain inflamed for several days. It can actually drag on for a while. Abscesses are not uncommon, especially depending on the amount of parenchyma involved. Sepsis, fistulae can happen, and you can meet these others. Here's our worst complication from a liver injury. And actually, this kid had a spleen injury that we embolized and then went home. came back about 4 weeks later, and this is a big pseudoaneurysm of his hepatic artery that actually occluded his portal vein. And this is all ischemic liver. And he ended up getting a liver transplant, or he lost his whole liver. And this was not noted on the initial imaging. And you can see some coils in his spleen, but we didn't. His liver we thought was normal when he was initially injured, but there was something obviously that injury was there because he didn't re-injure his liver. But even a rare injury, but a very devastating injury for him. So CAT scan has a high sensitivity and specificity for the diagnosis of liver injury, but we, for kids, obviously need to be concerned about radiation. Luckily, complications for liver injury in kids are very infrequent, but when they do occur, they can actually be severe. We've had some. I've had one kid get transferred in with a peritoneum full of bile that we had to tap and then stent, and a couple other kids with leaks that were difficult to control that we had to have our IR buddies stent. And I've had a mad crush on contrast enhanced ultrasound, and we just finished a pilot study using it, and we'll be hopefully presenting that soon. And I guess that's it. I had a bunch of references to say I didn't just make all that stuff up.
Thanks, Dave. That was great. It was a great combination of talks that I think hopefully we all learned a lot from. One question that is on my mind more and more recently, and it came up at the Pediatric Trauma Society, comes up at other meetings, is one is what's the difference? Is there a difference between liver and spleen? We often talk about them the same as far as non-operative management approach, and the other is when does that age change from when we can safely, for our adult colleagues, is it 16? Is it 18? We magically say at 16, above 16, you can go to the adult trauma center, but does that mean your spleen's an adult spleen, or is it older or younger? Do either of you or anybody else on the panel have any thoughts on those?
Well, I'm always happy to comment. So we've actually, I'm usually reluctant to say things that I'm doing because I don't want you guys to scoop me, but so we found that vital signs correlate really well with grade of injury for spleen injuries, but not for liver injuries. And we're working on studying a bunch of kids' vital signs after their liver injury to see if we can work backwards. Because the grading system for livers, to me, doesn't correlate at all with how the patients do. And it may be very loosely, but not the way the spleens tend to be pretty much on the money. I don't know what age. I suspect young adults could probably all be managed how we manage children. And what the age is probably into young adulthood, somewhere past the ages that we care for them. The adult data talks about people in their 40s or 50s being the cutoff.
When we were writing the atomic guideline, the problem that you have in the literature, because it was an evidence-based guideline, is that the papers, the age cutoffs are all over the place, and so you have some places that are cutting off at 10 and 12 and publishing their data, and other places that are cutting off at 21 and publishing their data, and then you have adult centers that are publishing on just adolescents. And the reality is we have no idea of when it becomes an adult organ, and you're not going to be able to tell by the literature that's out there. You're going to have to specifically study that to see whether or not adolescent patients, should be treated like adults or kids. If you are an adolescent and you're taking care of an adult center, you're treated like an adult. And if you're an adolescent and you're treated at a pediatric center, you're treated like a kid. Which one's better? I don't know. I'll tell you, when it comes to DVT prophylaxis, there's some misses at pediatric trauma centers where you have this little bump that occurs in DVTs. It's not huge, but it's noticeable in those 14, 15-year-olds that you don't have in the 16, 17-year-olds because they're being treated like adults and they're getting prophylaxis. So we've actually started being a lot more aggressive in DVT prophylaxis. I think there are going to be other areas where we need to really define who's a child and who's not, and age may not do it. There needs to be some way to do it.
Well, it's a great conversation, and I think John Petty thanks you for raising the DVT, since that's what he's going to close with this afternoon.